Now we will proceed for the last talk of today, and again it's a very important talk because we have seen in the last few years in our country there have been a surge of specialties specifically related to general medicine. In this era, how can we revive the role of the generalist? It's important for all of the internists. For the talk, we have got Professor Dr. Hashim Azam Khan. He has been my teacher and a true gentleman. So welcome on stage, Professor Dr. Hashim Sahab.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum to my colleagues, senior colleagues, trainees, and students, if any. I've slightly changed the topic. I was told to talk about the generalist, but I've changed the term to internist because in my view, generalist is a bit vague, so I settled for the internist term because it serves my purpose very well. Few declarations. Conflict of interest, yes, I'm definitely have a conflict of interest because myself I'm a proud internist, but don't consider this to be any way against the specialist. They are needed, they are very important to the medical science and medical field and the patient care, but I just wanted to emphasize the pivotal role of the internist in not only patient care but also in medical education. It's very important to understand the historical perspective of the internist. How did it all start? Where did it all start? Well, it started with this gentleman, the mythical healer, the so-called healer, and Mr. Asclepius, Hakim Luqman. You can see in this slide one of the oldest tablets from Greek mythology that Asclepius is trying to heal somebody by nature of his spells and trying to take out the demons, and he's been overlooked by the goddess of healing. But can you imagine who these people standing on the bedside are? They are the specialists. Sarcasm aside, this gentleman, Hippocrates, of course, long time ago, debunked the Asclepian theory of healing and the concept of medicine. He based his opinion that medicine is all about observation, consideration of the causes. And thanks to this gentleman, Avicenna, through his Qanun-i-Tib, Canon of Medicine, he emphasized the importance of internal medicine, internal physiology, and internal anatomy as the basis of human medicine and pathology. Quite later on, during the European Renaissance, Robert Koch actually is the founder of the term internal medicine in the 19th century. And many American physicians early in the 20th century actually studied medicine in Germany, and that's how internal medicine term was brought to the Western medicine. The term internal medicine in English has its etymology in the 19th century German term Innere Medicine. And it's all about internal medicine is all about the underlying internal causes, pathological causes of the disease. So internal medicine has a long history, and we have come through the historical perspective and we have found out what internal medicine is all about. So who is the internist? If you are a practitioner of internal medicine, who are you? What is your field? How far can you go? The definition is huge, it's complex. I can go on talking about the internist capacity of internist medicine indefinitely. But what is important to realize the last two sentences here, they have a lifelong relationship with the adult patient, and the recommendations are based on each patient's unique situation. They are probably the first doctor the patient is going to see, and they are probably the last doctor that the patient are going to see as well. So we are actually primary care physicians. The primary care physicians, the internists, see the big picture. They look at the complex pathological processes happening in comorbid conditions in unison. They are the doctor's doctors. How many of you haven't experienced a call from a subspecialty, from a pulmonologist, from a nephrologist, call to the medical unit on call? We have so-and-so patient, he's got this and this problem, can you help us out? So the internist deals with several different illnesses that may strike at the same time. They lead the patient care team. Their environment of practice varies from anything from hospital, where they're called hospitalists. They can work outside in outpatient care, as we do. They can practice in other clinical settings, like rehabilitation centers, long-term facilities, and health clinics. But what internists are not? Sometimes people do confuse internists with other kind of physicians. We are not family physicians. We are not general practitioners. We are not GPs. We are solely focused on the treatment of adults. We do not practice surgery, obs, gynae, ophthalmology, or pediatrics. So what's happening? Where are the internists? What is happening? Where are we going? Well, until the 1960s, the internists, the physician, so-called, because the Society of Physicians, that's what I wanted to emphasize, was the king. We did have physicians with special interests, special interest in diabetes, special interest in pulmonology, but then came mechanization. We had endoscopy, we had bronchoscopy, we developed angiography, and these skills required training and time. Unfortunately, we didn't have that. Hence the development of specialties. Nothing to be ashamed of, but we must emphasize that the development of specialties depends on financial incentives as well. And that's hence the branching out of medicine into different specialties. The Massachusetts Medical Society of Physician workforce highlighted the critical deficiency of internists in the coming years. So what are the challenges? Well, challenges or opportunities for general internal medicine, an excellent article by Shapiro. Medicine did not always have specialties, and the specialties development, as I said earlier on, economic self-interest and technological advances were the main reason for the specialties to come up. But they were also probably the reason in some specialties to go down. The decline in internal medicine has been substantial. If it's not early reversed, we face a prospect of the general internal medicine heading for the dustbin of history. So what are the problems? How do we look at these problems? Well, everything begins with a medical studentship, doesn't it? A very good study by Hure and colleagues in 2008 looked at the influences, the positive and negative influences of the medical students, at how they foresee themselves future interns or not. Roughly 23% of students reported that they were likely to enter an internal medicine training program because it's very exciting. But in the end, only 2% of the sample sought careers in general internal medicine. So what happened? Positive influences, intellectual challenge of internal medicine, continuity of care, quality of training, excellent. But the more paperwork, we have to fill in tons and tons of history sheets. And again, reality, the pay is less as internist. We need to develop strategy to counteract the decline in positive attitudes towards treating chronically ill patients that take place during training. So, in this challenging context, report by Larson, an extremely valuable call to the profession for radical change. I remember one of the older teachers doing a very long round, everybody attentive, listening to every word that the internist, the physician would say to the patient, the way they examined the patient. Gone are those times, unfortunately. Either we accept it or not. Gone are the days of genteel, long 2-hour, 3-hour rounds. I myself, when I do a long round, I notice my TMOs steadily getting less and less, and in the end, I only am 1 or 2 TMOs whose bed there are that I'm doing the round on. The newer generation is technical savvy. They want quick results. You can't expect a young internist trainee to stand with you for the next 3 hours and do the ward round. They get bored very quickly, and they want quick results. And they do see us getting bored with our life as well. So what about the trainees? We talked about the students. What about the trainees? Training that is needed to be internist is about 3 years, fine, but if anybody wants to have an extra specialty, this will require additional time and financial incentives. And this needs to be thought about larger profession will not welcome more generous pay for internists within a pot that is already not growing or expanding. We all know about the financial constraints of the health sector. So when you talk about internist or specialist, who is the best person to take care of the patient, internist or specialists? Well, hospitals have hospitalists, the internists who actually work in hospitals, have proven beyond doubt that they are the best people to treat patients in the hospital situation. Other studies have shown that some patients might be better off with specialist care. It may well be that the patients are best off with joint generalist specialist care in some instances and specialist cares in the others. But there's no doubt, studies have proven beyond doubt, that general internists provide equivalent or superior care in some situations, notably in patients with multiple chronic problems. So when you ask yourself who is the best, internist or specialist, the person who is at the center of these answers is the patient. We must think of the patient first before we decide who is the best doctor to take care of this patient. What are the parameters that characterize the patient who benefits? What are the levels of complexity of care? What skills are needed? What are the characteristics of the practice of the doctors? And what is missed if a generalist is not involved in the care of a patient with a particular disease or certain characteristics? The medical outcome study examines some of these issues. And we need to keep an open mind. We will not always be all the things to all the people. We probably will not be able to take care of all the patients all the time. But still, it should be possible to identify areas in which our work is associated with superior outcomes of greater cost effectiveness. We can't do it alone. Government institutions, funders, health authorities will have to look at us internists and see whether they are worth investing in. The challenge? Various specialist societies, we have the Society of Internal Physicians. What about societies of gastroenterology and pulmonology? Are they going to be happy when we take away their funds? And they're not going to be happy and altogether pleased with the notion of a refurbished internist playing increasing role into their fields. We have to convince them. Numerous studies have proven that probably internists in nearly every situation might be better in taking care of some of the patients. Counseling, more effective teachers on the inpatient services than are subspecialties. We are more effective in resource utilization. What about the utilization of the health budgets in broad hospital institutions which mainly deal with public health issues? Would you like to develop a department of cosmetic surgery in a public health hospital in which the primary cause for disease, as the VC Saab said, are communicable and preventable diseases? It's a very fashionable thing to have a cosmetic surgery department, but is it ethically right? So where do we go from here? The evidence and training systems are in place to make it possible to construct a healthcare system that optimally addresses the needs for all patients. That will not always mean handing the patient up to the line of the subspecialties. Certainly involve creating systems that monitor the care that is provided, that require that doctor who are narrowly constructed will always have access to resource and co-management opportunities that will serve the patient in the best interest, I doubt. The future of general internal medicine. Report and recommendation of Society of General Internal Medicine, Task Force in the Domain of General Internal Medicine by Larson, published in the Journal of General Internal Medicine. While remaining true to its core values and competencies, general internal medicine should stay both broad and deep-ranging, from uncomplicated primary care to continuous care of patients with multiple complex chronic issues. Postgraduate training should develop mastery wherever they practice. General internists should be able to lead the teams and be responsible for the care their team give. And we aim to provide most of the care that the patients require. And of course, I keep on coming back to the basic problem. Amjad Saab is gone, but probably he highlighted the issue of money, finances. So, how do we proceed from there? How do we convince people that we are probably in the best position to take care of patients? Three things. We must acquire and share knowledge, provide patient-centered, comprehensive, longitudinal care through treating complex and chronic illnesses, coordinate care with health systems, commitment to quality outcomes, commitment to preventive care, evidence-based practices, very important. The long list of things that we should be able to practice and we should be able to promote ourselves in. Education, commitment to lifelong learning, adaptability. Very common problem with internists nowadays. We get older, we are in the same humdrum kind of a life, not keeping pace with the modern aspects of internal medicine. And of course, new diseases, COVID, dengue. I had to study dengue again, I had to study chikungunya. Leadership must be a role that we must always have, and professionalism, duty to service, honor, integrity, respect for the others. And I ask you in the end, what would you like to do? Would you like to look at the tunnel vision and look at a very small part of the beautiful scenery ahead? Or would you like to have a broad vision and look at the whole scenery and enjoy? Would you like to sit in a room with many windows and enjoy the scenery outside and different views of the nature? Or would you like to sit in a huge building with multiple offices or multiple rooms, but your window will only be one? You will be only looking through the window of that room. So in my view, the internist, the primary care physicians will always be the center of patient care. The patient will always look to the primary physician. You can see the patient is looking to the primary care physician. The rest of the team is there to help, to guide, to counsel. We are not ignoring those people. We need them. So, finally, in my view, internists will always be first and specialists will always be second. And to quote the most famous internist, in fact, the founder of internal medicine, internist will always treat the patient while the specialist will treat the disease. Thank you very much.